Okay, we're going to go over Chapter 30. These are the skeletal muscle, bone, and joint disorder drugs. Vocabulary words to be familiarized with are alopecia, which is abnormal loss of hair or the abnormal absence of it. So if we're supposed to have hair in a particular area and it's not there, it's either been lost or it's not present, we call that alopecia. Autoimmune is a response in which antibodies are formed against self, so begin attacking one's own body or tissues. Dyspepsia is epigastric discomfort, aka layman's terms heartburn. Gout is a metabolic disorder in which high levels of uric acid cause severe joint pain, also called gouty arthritis. Paget's disease is another thing that we touch on. Bones grow too large and become weak. It's just one example of bone disorders that can occur. You can read over these skeletal muscle disorders. This is from your pharmacology book. Obviously, this pairs with your med-surg lecture that covers a wide variety of MS disorders. So look over these, kind of be particularly familiar with osteo and rheumatoid arthritis, gout, osteoporosis, and then we've mentioned Paget's. The picture here below indicates what presentation that Paget's takes in the kind of the bowed legs, the really overemphasized and overgrown long bones of the arms and legs. You can see that they're disproportionately sized against the trunk. Osteoporosis is a disease in which the bones become what I like to call like moth-eaten. They're less dense. They have decreased deposits of calcium and phosphorus in them, making them brittle and prone to break. I do want you to know and understand differences between osteoarthritis and rheumatoid arthritis. Again, this should be covered out of med-surg, so just a review. Osteoarthritis is known for morning stiffness that lasts less than 30 minutes. So it's that individual that once they get up and moving around, typically start feeling better. There is cartilage loss at the joints that causes discomfort with movements. They might have nodules, bony nodules, like on their fingers, which is called Heberden's nodules. That's not necessarily important to know. The pain and deformity of osteoarthritis is asymmetrical. So there's pain in one side and not necessarily the other. Now, can you have osteoarthritis in both your knees? Absolutely. But it typically will start in one and then begin in another. The difference with rheumatoid arthritis or RA is that it is an autoimmune disease. It is not a degenerative disease. So it doesn't occur over time with wear and tear. It's directly related to the inflammatory process and an autoimmune process. So the pain and the involved joints will be symmetrical. They will begin hurting bilaterally on each side. So both knees will experience RA at the same onset. It's related to an inflamed synovium. Morning stiffness will last more than 30 minutes. Moving around doesn't seem to provide the relief that osteoarthritis does. There's also deformities of the hands and feet that are common with RA that are kind of hallmark as well. Okay, there's a variety of drugs used to treat musculoskeletal injuries and disorders. We're going to go over the skeletal muscle relaxants. We're going to talk about DMARDs, which are disease-modifying anti-rheumatic drugs. We're going to talk about the bone reabsorption inhibitors, including the biphosphonates. That word is spelled wrong. And then we're going to look at the uric acid inhibitors for the treatment of gout. The skeletal muscle relaxants are the ones that are seen here. Baclofen is a common drug use. Crisprodol, cyclobenzaprine is another very common one that you'll see. Diazepam is also used as a skeletal muscle relaxant. We just covered that in our last lecture, and you should be able to identify it out of that non-barbiturate grouping in one of the benzodiazepines. You can look over those. Another one there at the bottom, tizanidine is another one that you'll see common in practice, Xanaflex. Okay, so uses and adverse reactions of the skeletal muscle relaxants. They treat painful musculoskeletal conditions. They can be used in conjunction with pain relievers, either the non-opioids or opioid pain relievers. Typically depends on the severity of the pain. Diazepam that we just mentioned, which is a benzo, is useful for its ability to relieve pain in musculoskeletal conditions. Other relaxants appear to work on their sedative action as well. Cyclobenzaprine has an effect on muscle tone, so it is especially helpful for decreasing muscle spasm. Adverse reaction of all of the skeletal muscle relaxants is going to be drowsiness. This is the most common. Also included is sedation, which is a little bit different than drowsiness. Sedation is that more I guess you would say pronounced drowsiness, that forced sleep state, sleepiness, lethargy, constipation, or diarrhea, depending, bradycardia or tachycardia. Again, it could be labile, and then rash. But the most common reaction is definitely drowsiness with these medications. It's pretty common as well. We're not going to give this medication to anybody that has a known hypersensitivity. Surprise, surprise. Baclofen is contraindicated in muscle spasms that are caused by rheumatic disorders. So you're not going to administer baclofen, aka Flexeril, to somebody that suffers from RA. So it's okay for osteoarthritis, but not rheumatoid. The Carisoprodol is contraindicated in patients with known hypersensitivity to meprobamate. Cyclobenzaprine is contraindicated in patients that have had a recent MI, cardiac conduction disorder, aka an arrhythmia, and hyperthyroidism, and do not give within 14 days of an MAOI. So the issue with cyclobenzaprine is the effect that it has on the cardiac muscle. So it can further propagate cardiac conduction disorder or make an arrhythmia worse. If somebody's had an MI, it could mess with the electric current, basically, that controls conduction. And then hyperthyroidism also causes these similar cardiac issues. So if you were to give this medication with somebody that had it, you could only increase the possibility of having cardiac dysfunction. Dantrolene is contraindicated during lactation and in patients that have hepatic disease and muscle spasm caused by rheumatic disorder. So again, you have to understand what particular reason they're getting this medication, and there's a couple of them that you certainly don't want to give if they have RA. So the big ones I want you to know, though, are do not take these with alcohol or any other CNS depressants because of their ability to sedate, and they are not intended for more than 2 to 3 weeks of consecutive use. So they're not to be taken all the time. They're not a sure fix, okay? Precautions with these medications. Again, you want to be careful with most medications, given cautiously if someone has kidney or liver disease. Carisoprodol is certainly one that you want to be very careful, including in pregnancy and lactation. We've already talked about cyclobenzaprine and its effect on the cardiac system. Dantrolene, do not give in pregnancy. Generally speaking, the whole skeletal muscle relaxant group, be very careful if the patient has a history of CVA or stroke, cerebral palsy, Parkinsonism, or seizure disorders. And again, it's just how it might affect nerve impulses in each of these types of disorders. I do want you to know all of these precautions at the top, paying close attention to each of them, and specifically the dangers of administering these medications in pregnancy. Take a look at the skeletal muscle interactions chart. The most important things, though, to remember are to not give these with other CNS depressants, including alcohol. This also includes things that have the ability to sedate, like sedatives or antihistamines, because of increased CNS depressant possibility. Okay, we're going to move on to the DMARDs. So these are the disease modifying anti-rheumatic drugs. The hydroxychloroquine or Plaquenil is probably the most well-known, maybe not in this time, but it is helpful for the treatment of rheumatoid arthritis, but it's also an anti-malarial drug, interestingly enough. You should see the sulfasalazine looking familiar from previous discussions. So being a sulfa-based drug, you know that you're going to definitely assess for a certain type of allergy with that one. But because of its anti-inflammatory properties, it's helpful for rheumatoid arthritis, Crohn's disease, ulcerative colitis treatment. Note there are a couple of drugs that are mentioned within the book, but not in the DMARDs listing. I'm not going to try to pronounce these except for cyclosporine and gold salts. These four things here listed are considered DMARDs, but they are cytotoxic and reserved for life-threatening issues only. So if you were to look up any of these medications, you would see that they certainly are a DMARD, but they're not going to be administered regularly. Others listed here, you've seen Humira probably advertised on TV, as well as Enbrel, all newer type treatments for rheumatoid arthritis. So as you guessed, the big use for DMARDs is for the treatment of RA. They're very useful as an immunosuppressant. So because RA is an autoimmune disease, these are very strong and specific anti-inflammatories or immunosuppressives that kind of stop that autoimmune response. DMARDs are also used for cancer therapy in Crohn's disease, which is also an autoimmune condition, and as well as with fibromyalgia because of the inflammatory properties of it. Adverse reaction are nausea, stomatitis, which if you remember are sores in the mouth, and alopecia or unusual or undesired hair loss. So remember with those sulfa-based drugs, what you need to assess. You need to monitor for ocular changes, GI upset, and mild pancytopenia. Pancytopenia is widespread blood cell decrease. So lowered red blood cells, lowered white blood cells, lowered everything. Because DMARDs are designed to produce immunosuppression, your main concern is going to be infection prevention. So we are lowering their immunity by decreasing their immune system. So even a cold or an open sore can become life-threatening to these individuals. So this is very important. I would certainly pay attention to that nursing alert. This is the greatest risk of this medication. These medications are not to be given in anyone that has a hypersensitivity, specifically to methotrexate. It's contraindicated in patients with renal insufficiency, liver disease, if they abuse alcohol, if they're pancytopenic or have a folate deficiency. Methotrexate is a pretty nasty drug, very effective, but people have to be relatively healthy in order to take it. Etanercept, adalimumab, and infliximab. You can read those and maybe pronounce it a little better than I can. Should not be used in patients with congestive heart failure or neurologic demyelinating diseases. Pay close attention to the contraindications from methotrexate. For methotrexate dosing, you're going to want to use a calendar or other device to ensure this drug is taken on the same day of the week each time. Methotrexate is typically, now don't write it in stone, but typically not ordered every single day. It's either given once a week, it might be given twice a week, or Monday, Wednesday, Fridays, but it's always going to be set on a regularly scheduled dosing schedules or timing. So you want to make sure that the patient knows that they take it the same day. They're not to miss. It shouldn't be a day late. It's definitely will affect the efficacy of the drug. Notify the provider immediately if any of these things occur. If they develop sores in the mouth or just a sore mouth in general, if they have diarrhea, sore throat, bruising, rash, itching, nausea, or vomiting. They could be signs of serious issues, including liver damage, infection, lots of different things. Women of childbearing age should use contraception during therapy and for 8 weeks following. So it's definitely something that you do not want to take while pregnant. Methotrexate is actually a component of some morning after pills. So it can cause spontaneous abortion or be very teratogenic and cause birth defects. So dangerous medication. Precautions in patients with obesity, diabetes, hepatitis B or C because of the liver involvement or damage. Women should not become pregnant. We talked about that. Sexual partners should use barrier contraception to prevent transmission of the drug via semen. So that's kind of crazy. That medication can actually be transferred to another person along with the risks of taking that medication. Sulfa antibiotics have increased risk of methotrexate toxicity. Taking aspirins and NSAIDs with it can also increase the toxicity potential for methotrexate. Okay, so the bone reabsorption inhibitors or the bisphosphonates are listed here. Please note the little symbol. This drug should be administered at least an hour before or 2 hours after a meal. So we'll talk about some of the other administration considerations, but these are drugs that are used to keep calcium in the bone, to keep the bone strong, and for the prevention of osteoporosis. Some of these you've probably seen, again, advertised on TV, Fosamax, Aldentronate, Boniva, Reclast, Actonel. I think it was Boniva that Sally Fields advertised, some years ago. I don't know if you guys saw that one. They've been around for quite a while, but there's some special considerations that people need to follow when they're taking these. Here's a couple of others. Avista. So they act on the bone by inhibiting normal and abnormal bone resorption. So you probably learned in med surg. So this is just a recap. We only have a certain amount of time in the beginning of our life into our 20s where we're depositing calcium in the bone bank, I call it, where bones are, growing and making calcium deposits. After that, all that is occurring, we don't continue growing bone, we're just remodeling it. So calcium comes in and goes as serum and bone levels fluctuate in and out. And hopefully you guys remember, serum calcium levels should be low, bone calcium levels should be really high, and calcium and phosphorus work in an inverse relationship to balance the amount of calcium in the bone, the hardness of the bone, and the health of the bone. So essentially with osteoporosis, we have a serious imbalance of the bone resorption where, all that calcium is just being pulled right out into the serum levels, leaving the bone bereft and emptied of its calcium, or the person didn't make enough deposits in the bank. And now, because of hormonal influences and things, especially with menopause, they're not able to maintain the bone health like they should. So this is used for treatment for osteoporosis, as I mentioned. It's especially in postmenopausal men and women. Of course, men aren't postmenopausal. I said that kind of strange. But in postmenopausal women, and then also in men who can suffer from osteoporosis, but not menopause, thank goodness. Hypercalcemia of malignant diseases can lower serum calcium levels by putting it into the bone. So we talked about some of those malignant type tumors like the pheochromocytomas that can just radically and randomly start producing all of this calcium that floods the bloodstream. We can administer these bisphosphonates that take that calcium and put it in the bone where it's better use, and we don't have the dangerous risks of having all of those, all that extra calcium in the bloodstream. It's also used in the treatment of Paget's disease to help strengthen and solidify those bones, again, by maintaining calcium levels. For chronic care, drug treatment for osteoporosis, it typically lasts about 5 years of a bisphosphonate administration. After that time, a drug holiday is recommended. So, the doctor will decide how long or short that time is depending on the person's particular case. Okay, adverse reactions of the bisphosphonates are nausea, diarrhea, and then the biggest one is increased or recurrent bone pain. It's almost like, kind of growing pains because we're pushing all of that calcium into the bone and actually strengthening it, but that can hurt. People can also suffer other issues. And I really should have bolded acid regurgitation. That's a big one. Please put a star there, and by dysphagia, and I would write dyspepsia there. There's typically very low adverse reactions with proper administration. There's nothing, serious or life-threatening about any of that. And there are some things that they can do to make it better. We're not going to give this medication to anybody who's allergic to it, obviously. Alendronate and Risedronate, Actonel, is contraindicated in patients that have low blood calcium. So that makes sense. If there is no calcium in the serum level to put into the bone, it could essentially make them even further hypocalcemic, which, if you recall, will cause extreme spasticity and other potentially dangerous reactions, especially like arrhythmias and things like that. All bisphosphonates are contraindicated in patients that have delayed esophageal emptying or renal impairment. The esophageal emptying issue is because of the potential for acid regurgitation, the erosion of the esophagus, and that kind of thing that can be related to the combination of this drug and that difficulty, if you will. As far as interactions with these medications, I think if you would just look over that list, aspirin's probably the most concerning, just because it can cause an increased risk of GI bleed. We already have a medication that can be pretty acidic on the stomach, yet absolutely has to be taken with no food on board. So if they're also taking aspirin, which has that same increased GI bleed risk, it's only going to compound the issue. We've already mentioned the 5-year treatment with the drug holiday. When bisphosphonates are administered, serum calcium levels have to be checked before, during, and after therapy. That's very important to remember. That's what it's all about. What's their blood calcium level? We should see it go down, but not dangerously so. Adhering to specific routine of the prescribed bisphosphonate will increase efficacy and decrease adverse reaction potential. A lot of these medications are dosed once monthly, and it has to be given at the same time each month. So they need to either write it on the calendar, set it in their phone. They need to make sure they get their medication when it is prescribed. In addition to checking calcium levels, they may actually be prescribed a calcium supplement to help support the action of this medication. So I would look over that purpley pink box at the bottom of the slide, and definitely pay attention to the things that are mentioned here. Like I said, there's some very specific administration guidelines to follow. So, uh, like I already mentioned before, make sure you use a calendar or cell phone alert to remember the monthly dose. Don't you can do things like not make your coffee the night before if that's something the patient does. You can tell them don't do that, so you remember today's the day. I don't drink my coffee. I get up and I'm going to take my medication. So they do need to take it with 6 to 8 ounces of water. And then after that, no more fluid or food for 30 minutes to an hour. So they need to take it with a full glass of water, but then not and eat or drink after that. They also need to remain sitting upright after that. So, they can't go lay back down like, oh, I can't eat breakfast, so I'll go lay back down and rest a while, because it can cause some severe, regurgitation of acid and damage to the esophagus and the cardiac sphincter of the stomach and that kind of thing. Our uric acid inhibitors are medications that decrease the buildup of uric acid, which collects in the joints and is known commonly as gout. Allopurinol is probably one of the most common. Colchicine is also given and will often be given with allopurinol for joint treatment, symbiotic treatment. Um, Probenecid is another one that you will definitely see. Pegloticase, we'll talk about that one. It's IV. It's a rescue type medication if they actually have an acute inflammation of gout. So, and please note with the pegloticase, the anaphylaxis can occur and is actually considered pretty common with that medication. So patients are always pre-medicated with antihistamines and corticosteroids before those administrations. And each time they get one, the risk of anaphylaxis will go up as well. So that's always okay. Precautions for all the medications excuse me, all the uric acid inhibitors with those that have renal impairment and during pregnancy. Allopurinol is very hard on the liver, and so you need to be careful if they already have liver impairment. Probenecid is used cautiously in patients who are hypersensitive to sulfa drugs. There is a cross sensitivity in patients that have peptic ulcer disease. Colchicine is used in caution with older adults. You definitely need to be aware of that. I would be aware of all of these precautions for these different medications. They're important risks for each of them. As I mentioned before, you definitely need to push fluids with the administration of these medications. So at least 8 ounce glasses of water a day. Push them up to 3,000 milliliters a day. So we typically tell people to drink 2 to 2,500 milliliters of fluid if it's not, unless it's contraindicated. These people need to drink even more than that. They should be drinking upwards of 3,000 milliliters a day in order to flush those uric acid crystals out so that they're not inflaming the joints. You can look at the interactions that these medications might have with certain drugs. There's actually several that can occur. I wanted to touch a little bit on multiple sclerosis. There is a drug that's listed. It's a biologic that's specifically developed to treat MS that's not really discussed in any of the other groups. If you don't know what MS is, and again, you probably covered this in MedSurg, so just to review, it's an inflammatory disorder, but it attacks the nerve itself. It is specifically damaging to the optic nerve. It can cause neuritis, and it essentially starts breaking down that myelin sheath of the neuron itself. So it can happen anywhere between 15 and 50 years of age. So kind of a relatively long span of time. But the people, typically start feeling clumsy, notice muscle weakness. They'll start having paresthesias, which, if you remember, is that pins and needles feeling. And that's just that nerve damage beginning to happen. Ultimately, they begin developing the optic neuritis, or inflammation of the optic nerve, which can be very painful and can be blinding, if not, cause visual disturbance at the least. So it's treated with several different types of medications, including interferon, which helps with the autoimmune portion of the disease, corticosteroids, which stop inflammation, but then also this biologic medication. So I didn't want to pass over it. I wanted to touch on it and make sure that you understood um, the what this medication was developed to treat. Nursing considerations for all of these meds, I would definitely read over these. Make sure that you, as always, look at the patient's history, summary of the disorder. When did it start? What have they done for treatment? Did it work? Examine all of the affected joints, the extremities. Look over the skin. Look for any joint deformity that would be indicative of an advanced stage, either degenerative or autoimmune process. Look at the mobility. Look at the person's gait. Ask about their strength, their ability to perform ADLs. If somebody has gout, examine the affected joints, and note the appearance of the skin over the joints, and look for any enlargement that can indicate inflammation. Ask about pain. See if it's red. Feel if it's warm. Osteoporosis, assess for pain in the upper and lower back or hip, where it's most common. For acute gout, response to therapy may occur in hours. It's very important that if you start someone on a uric acid inhibitor, that if they don't have relief in 2 to 3 days, you need to notify the provider immediately, because it should actually turn around and begin correcting fairly soon. So that's an important thing to remember. For your ongoing assessment after you've administered the medication, continue to inspect the joints involved every 1 to 2 hours in the acute care environment. Make sure that there's a response for a therapy. To the therapy. Ask the patients about pain relief, adverse drug reactions, if they're experiencing relief at all. Be alert to skin rash, fever, cough, or easy bruising. Skin rash is very common with all the medications we just discussed. Easy bruising could be a liver issue because we have an issue with clotting factors. Be attentive to the patient complaints like visual changes, tinnitus, hearing loss. They could be indicators of some sort of neural type damage. Observe closely for the development of adverse reactions like thrombocytopenia or leukopenia, because as we saw, pancytopenia is one of the issues with several of these medications. Immediately bring all adverse reactions or suspected adverse reactions to the attention of the primary healthcare provider. Let's see. I have a note here. Especially be alert to reactions such as skin rash, fever, cough, or easy bruising. If you will remember, those were big deals for the uric acid inhibitors and for the DMARDs, but also kind of across the board on everything. Encourage liberal fluid intake, especially with those uric acid inhibitors. We got to flush that out. Administer the bisphosphonates with 6 to 8 ounces of water while the patient is in an upright position and remains in an upright position for 30 minutes to an hour, and does not consume any food for 30 minutes to an hour, nor drink any other fluids. Administer DMARDs, uric acid inhibitors, and skeletal muscle relaxants with or immediately after meals to prevent that gastric distress. So bisphosphonates, nothing. DMARDs, the gout medications, and muscle relaxants are better with food on the stomach. Evaluate patient carefully before allowing the patient to ambulate alone. The degenerative nature or the pain of the musculoskeletal disorder itself can cause safety issues with activity and with ambulation, and certainly administering medications can complicate those issues. Notify the primary healthcare provider before the next dose is due, or if drowsiness is severe. Assist the assist the client with ambulatory activities if drowsiness occurs. Definitely avoid alcohol and CNS depressants with muscle relaxers. That's very important. I would definitely make sure that you remember that. Some DMARD treatments for RA might require sub-Q injections. So if you remember, the DMARDs are often used for the treatment of RA. So make sure that the patient and family know how to administer, and that the patient has the dexterity of their fingers to administer those subcutaneous injections. If they cannot, you need to make sure that a family member can administer the medication. Patient and family member should demonstrate for you all the proper steps to give that injection. They also should be able to verbalize to you how often they're going to do that, if it's every week, on what day of the week, all of those administration considerations that we talked about, the family and patient should be able to verbalize back to. The only herbal mentioned in the book is glucosamine and chondroitin, given together. Or they can be used alone, but often given together to treat arthritis, particularly osteoarthritis. Chondroitin is thought to increase the synovial fluid, so it gives the joint more lubrication, while the glucosamine increases regrowth of damaged cartilage, so kind of builds that padding back a little bit. It seems to be a very, proven and supportive thing. It certainly doesn't hurt. Sometimes I think even some orthopods or orthopedic physicians will recommend their use for certain degenerative type disorders. If you have any questions about this lecture, do not hesitate to reach out to me. This one had a lot more information in it, so I definitely want to make sure that if there's any kind of confusion or anything, we take care of that. If you ask me a question, I will make sure to send the answer out to everyone in the class. So happy studying.